This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. I'm Jacob Schwartzman, here with Editor-in-Chief of the Journal of Vascular Surgery, Dr. Peter Gloviczki. Today, we are excited to have our first episode in a new series, the JVS Venous and Lymphatic Editor's Choice, which will cover articles from the JVS-VL every other month as new issues come out. Dr. Gloviczki, welcome back, and thank you again for joining us.
Hi, Jacob. It's a real pleasure to be back.
Before we start discussing the papers, would you like to take a little moment to tell us a little bit about the JVS-VL, what's it about, and how it came to be?
Oh, I would be happy to. The Journal of Vascular Surgery, Venous and Lymphatic Disorders, that we call JVS-VL, is our second journal. It was started 7 years ago by then editors Dr. Sidavi and Perler. It is a collaboration between the Society for Vascular Surgery and the American Venous Forum. And within a very short period of time, this journal became the leading international journal in its category, with a focus on the investigation, prevention, and management of venous and lymphatic disorders. Especially last year, the journal performed exceptionally well. We have an impact factor now of 2.69, considering that 4 years ago we had no impact factor yet. So the journal is increasing both in impact and in content. It is a bi-monthly journal that's led by my co-editor, Dr. Peter Lorenz, and we have a great editorial board with Greg Moneda, Sine Shortell, Ruth Bush, Paul DeMuzio, and Daniel Hahn, and an exceptionally strong and expert international editorial board that consists of leaders of the American Venous Forum and experts from all over the world, and of course, experts and leaders in the Society for Vascular Surgery as well. So we are looking forward very much to further increase this journal. We have now a separate website, jvsvenous.org, where you can also submit your manuscript. And the journal has all the features of all the JVS journals, including our visual abstracts, for instance, of the papers that we are going to discuss today. And it's good to know that all these papers are available free of charge on the JVS website for the month of January. So I encourage everybody to read the JVS-VL and also to contribute to this journal.
Thank you very much for that, and it's great to be collaborating with you on this journal as well. And with that in mind, let's jump right in. Our first paper is titled Quality of Life After Pharmacomechanical Catheter-Directed Thrombolysis for Proximal Deep Venous Thrombosis by Dr. Khan and colleagues. To remind our listeners, this is the CME paper of the month, and you can find out more information about this on the JVS website. This study is a quality of life analysis of patients who were previously enrolled in the acute venous thrombosis, thrombus removal with adjunctive catheter-directed thrombolysis, or ATTRACT trial, which originally aimed to decrease rates of post-thrombotic syndrome, or PTS, by performing pharmacomechanical catheter-directed thrombolysis for acute DVT. While the incidence of PTS was similar between groups in that study, the severity of PTS was reduced and resolution of acute symptoms was quicker in the thrombolysis group. We will post a link to this original paper in our show notes. The current paper describes the results of quality of life surveys administered to patients from that study during their 1, 6, 12, 18, and 24-month follow-up visits. The venous insufficiency epidemiologic and economic study quality of life/symptom scale was used to assess vein-specific quality of life measures, while the medical outcome study 36-item short form health survey, or SF36, was used for general quality of life. 336 patients were assigned to thrombolysis and 355 to no thrombolysis in the original study. In the intervention arm, veins QOL scores improved on average by 3.9 more points in the overall 24-month follow-up period than in the control arm. Breaking it down by individual months, the differences were statistically significant at 1 and 6 months, but not thereafter. With regards to overall quality of life, SF36 scores were better by 2.4 points in the intervention arm at 1 month, but not significantly different elsewhere. Subgroup analysis demonstrated that the majority of the benefit occurred in patients with iliofemoral DVT, with statistically significant improvements in the veins QOL score at all measured time points, whereas no benefit was seen at any point in the femoral popliteal DVTs. So, Dr. Gloviczki, based on these findings, there appears to be a strong signal in favor of treating iliofemoral DVTs more aggressively. Is this in line with what we know about DVT management today?
Well, I don't know how strong a signal this really is, but it certainly reinforces in most experts who do catheter-directed thrombolysis in patients with iliofemoral deep vein thrombosis that this is indeed an effective procedure. It was unfortunate that the study, the ATTRACT trial that was published and led by Dr. Vedantam from St. Louis, originally really did not show a benefit in preventing post-thrombotic syndrome, and at the same time showed an increased risk of bleeding in patients who had thrombolytic treatment. So a sub-analysis was needed, like this study or the second paper from the ATTRACT trial that was reported by Dr. Cameroda as the first author, that actually is a little bit more revealing and tells us about the benefit of endovascular intervention in those patients who have iliofemoral deep vein thrombosis. So I think, as you predicted in your question, there is an increased enthusiasm in endovascular treatment of iliofemoral DVT, and now we have some additional data that confirm that indeed there is benefit and certainly disease-specific quality of life after iliofemoral deep vein thrombosis treatment with thrombolysis was improved all the way up to 2 years after the procedure.
So on the flip side, the study did not show much benefit in terms of quality of life, at least for patients with femoral popliteal DVTs. Should we not be offering these patients a thrombolysis at all, given that there's the risk of bleeding, but no major benefit that we can see?
I have to agree that there is not a strong evidence for iliofemoral deep vein thrombosis to benefit from thrombolysis treatment, and there is a very slim, if any, evidence that currently there is benefit from thrombolytic treatment in femoral popliteal deep vein thrombosis. Clearly, the quality of life data do not support it. It was interesting that in the ATTRACT trial, indeed, the bleeding complications were actually quite significant in the femoral popliteal treatment group. So I think currently we really should focus our efforts to prove the benefit thrombolytic treatment in iliofemoral deep vein thrombosis and not in femoral popliteal DVT.
So, based on the results of this paper, how should we adapt our practice and how should we counsel our patients?
Well, I think we have to tell our patients that thrombolysis carries an increased risk of bleeding. But again, as I pointed out, while in the ATTRACT trial, this difference was statistically significant, with a 1.7% bleeding risk in the treated patients versus 0.3 in the non-treated patients. In the subgroup analysis, interesting enough, the bleeding complications in iliofemoral DVT treatment was not statistically significant, even though numerically it was. So in spite of these, statistical differences, I think we should inform our patients that there is an increased risk of bleeding. But I believe that the ATTRACT trial alone did not change the enthusiasm for endovascular treatment in patients with iliofemoral deep vein thrombosis. So I believe we will need further studies focusing on iliofemoral deep vein thrombosis only, because in the abstract trial we clearly had a mixed group of the iliac, femoral, and popliteal deep vein thrombosis patients. And I believe that the patients should be properly informed. And now with the additional data of benefit in quality of life, I think we have more reasons to propose this treatment to our patients. This would also be in line with the SVS-AVF guidelines, where we, even though the evidence was not strong, but we recommended a strategy of thrombus removal in patients with acute iliofemoral deep vein thrombosis.
Thank you very much for that summary. We'll move on to the next paper. This paper is titled Spontaneous Hemorrhage from Varicose Veins, a Single Center Experience by Dr. Hingorani and colleagues. This is a case series of 32 patients who presented with spontaneous bleeding from varicose veins at a single center between 2015 and 2017. The authors found that half the patients who bled experienced contact with warm water immediately prior to the bleed. Local wound care was sufficient for hemostasis in all the cases, so none of them required surgery. The distribution of disease varied as well, with 28 patients having significant GSV reflux, 19 patients having saphenous vein reflux, 1 patient with accessory saphenous vein reflux, 8 patients with femoral vein reflux, and 6 patients with popliteal vein reflux. 20 total patients required at least one ablation procedure. And interestingly, patients who bled after warm water contact had significantly shorter healing times compared to those that didn't, and that's 1.75 weeks versus 3.5 weeks, so about half. Finally, ulcer recurrence was uncommon, with only 3 of the patients requiring repeat Una-boot therapy, and no recurrences of bleeding were observed. So, Dr. Gloviczki, this is a relatively uncommon event, and we typically don't think of varicose veins as causing bleeding issues, but clearly it can occur. How should we be counseling our varicose vein patients to minimize bleeding-related problems?
Well, as you said, this is a rare finding. It occurred in 4% of the patients treated during the same period by this busy group for varicose veins, but it occurs and it can cause severe problem, obviously even exsanguinating bleeding. And when you read the literature, there have been even fatal bleeding attributed to hemorrhage from varicose veins. So we need to take it seriously, and the patients are obviously very scared when they wake up in the morning or finish their shower and they are standing in a pool of blood. So this is a paper that gives us some real good advice, or actually multiple advices. It's telling us that half of the patients actually had bleeding when they were taking a shower with hot water. So it's a combination of increased temperature that causes a vasodilation of the skin circulation, and obviously vasodilation of the superficial veins and venules, which are the source of the bleeding. And it also, the standing position contributes to the bleeding complication with the increased gravity and the increased hydrostatic pressure. So if the patient has superficial varicosity, if the patient has any skin changes, specifically very thin skin over the varicose veins, if there is actually a history of bleeding, or if the patient is on anticoagulation or antiplatelet treatment, the combination of these factors, especially then exposure to hot water, can cause acute bleeding. I think we should all, tell our patients about these possibilities if we think that the physical exam shows that there is a chance that the patient can bleed.
The authors mentioned difficulty with obtaining prior authorization for endovenous ablation as a barrier to using this treatment during the initial bleeding episode. Have you experienced this, and should we as vascular surgeons be advocating for insurance companies to maybe allow us to use this therapy in an emergency setting?
Well, I think we should treat the underlying cause. One good message from this paper is that all bleeding stopped with, local compression, leg elevation, and applying Unna-boot on the patient. So I have to agree, although I rarely agree with insurance companies, that if the patient has obvious axial incompetence, sure, that is something that should be reimbursed and approved. But if the patient does not have incompetent axial veins, then just because there is a bleeding episode, that alone does not justify ablation of the saphenous vein. So we have to treat the cause. And if the cause is a local varicose cluster, then that has to be treated appropriately. If the cause or the contributing cause is an axial incompetence, then that should be treated. But I fully agree with you that bleeding from varicose vein should be considered an emergency, and any appropriate treatment should be reimbursed.
Thank you very much. The next paper is titled Factors Predicting Failure of Retrieval of Inferior Vena Cava Filters by Morrow and colleagues. This is a retrospective study from 2011 to 2018, looking at patients with IVC filters who undergo attempted retrieval. The total 294 patients underwent a total of 295 retrieval attempts over this time period, with an overall success rate of 84.4%. Patient characteristics associated with retrieval failure included female gender and history of hypercoagulability. Temporary filters were more likely to undergo successful retrieval than permanent filters, 85 versus 61%. Retrieval failure was associated with significantly longer dwell times, median 375 versus 196 days. Longer dwell times were also associated with increased chance of filter hook and hook or collar eroding through the caval wall, obviously making retrieval more difficult. Not surprisingly, filters with the hook penetrating the caval wall had high failure rates of 48%, and filters with both the hook and collar penetrating the caval wall had even higher failure rates of 66.7%. The authors used some complex retrieval methods, including endobronchial forceps, ballooning, or snaring the filter collar. These assisted in retrieval of some filters. However, the necessity of using such methods was obviously associated with a higher failure rate of 56%. Finally, the risk of periprocedural complications was low, with no IVC ruptures, morbidity, or mortality occurring within 30 days of retrieval attempt. So, Dr. Gloviczki, there are multiple striking figures presented in this paper. What findings did you find most interesting?
Well, again, the topic is always interesting because we continue to fail in removing IVC filters that need to be removed. According to the last systematic review, only about 37-38% of the removable filters are removed. So the first reason we published this paper, because it is extremely important that we have a protocol, and every hospital has a protocol that IVC filters are removed once they are not medically indicated. The most interesting finding is that penetration of the IVC wall by the tines of the filter occurred in 98.6%. So it is not the exception that these tines penetrate the wall, it is the rule. The paper pointed out the reasons and looked at factors that predicted removal failure. They found anatomic factors, but also it was interesting to see that female gender was a factor of failure to remove the IVC filters. It was not surprising to see that it is much more difficult to remove the permanent filters than the temporary filters. On the other hand, another interesting number that of the entire group of 294 patients, practically all, 95.6%, got a temporary filter and not a permanent filter. So clearly the trend is that we place temporary filters, and rarely do we place a permanent filter these days. And then, the anatomic findings were obvious that if you have more extensive perforation of the filter through the caval wall, it's more difficult. If the hook and the cone of the filter is outside, those are the ones that is extremely difficult or even impossible to remove. One of the major findings was also not a big surprise that the dwell time is very important. If the removal was successful, the dwell time was 196 days. If the removal was not successful, the average dwell time was 375 days. So the longer the filters stay in, the more difficult it is to remove it.
So as you mentioned, dwell time is extremely important, and keeping track of these patients is also important. You also mentioned a protocol for retrieving these filters in a timely manner. How can we as vascular surgeons do a better job of that? And how do we deal with getting everybody on the same page in terms of the importance of removing these and switching people onto therapeutic anticoagulation or not, depending on whether it's appropriate, in order to prevent things like penetration of the IVC due to indwelling filters that are in too long?
Well, I mentioned the protocol, and I think every institution and every group should have a protocol when they place a filter. Patient information is very important. Many patients who have filters don't even know that they have a filter, or they know that they have a filter, they don't know that those filters have to be removed. So I think placement and removal should be part of the pre-procedure planning. And if we tell the patient that we place these filters for such and such reason, and we plan to remove it at a time when it's appropriate, and I think when both the physician and the patient are on the same page, there is a much better chance that much more removable filters will be removed at a time when the success rate of removal is very high.
One last question. The authors of this paper noted that some of their patients had bowel invasion or invasion of the spinal column by IVC filter tines, and naturally this increases the risks associated with removing these filters. Do you see any downsides to attempting filter retrieval in certain patients, or are there any particular situations we should avoid doing that?
Well, there are certainly situations where we should avoid doing it. The filter tines, as you mentioned, can penetrate into any organ, but it can certainly cause problems if it becomes infected. The tines that get into the bowel or into the gallbladder can get infected. I was just presented a patient not long ago who had a duodenal perforation, an aortic perforation, and developed a mycotic aneurysm from the filter. You can have a psoas abscess from the filter. So every patient where there is organ penetration should be treated individually. And while I understand that they can be removed easily, it may not be the solution of the problem of that patient, because that patient may need additional procedures. Also, in my experience, those tines that penetrate into the spine, sometimes very difficult or not impossible to remove, or when you remove it, a portion of the filter breaks off and it still remains in the patient. So needless to say, you have to image the patient carefully and examine the specimen once you removed it to be sure that you removed all portion of the filter.
Thank you very much. Our last paper is titled False Negative Upper Extremity Ultrasound in the Initial Evaluation of Patients with Suspected Subclavian Vein Thrombosis Due to Thoracic Outlet Syndrome, Paget-Schroetter Syndrome, by Dr. Brownie and colleagues. This is a retrospective study from 2008 to 2017 of patients who underwent surgery for venous thoracic outlet syndrome that evaluates the utility of upper extremity venous duplex in establishing this diagnosis. Of the 339 patients who underwent surgery for venous TOS, 214 had complete ultrasound data and were included in the analysis. For these patients, the mean time between symptom onset and initial ultrasound was approximately 24 days and was only positive in 79% of patients, which corresponds to a false negative rate of 21%. Among the false negative ultrasound reports, only 18% described limitations of the study to visualize the central SVC or possible central venous obstruction of the thoracic outlet. The mean time between initial ultrasound and definitive imaging was 49 days. While patients with a positive versus false negative initial ultrasound did not differ with regards to that time period, a significantly higher proportion of patients with positive ultrasound findings underwent definitive imaging within 48 hours, 44 versus 24%. While there was no significant difference between positive and false negative groups with regards to incidence of external venolysis or patch angioplasty reconstruction when these patients were eventually taken to surgery, patients with false negative ultrasounds did end up getting significantly more axillary SVC bypasses, which the authors concluded that false negative ultrasounds may delay management, resulting in progression of the thrombus, leading to patients requiring a axillary SVC bypass. So, Dr. Gloviczki, why do you think there is such a high rate of false negative venous duplexes in this study, and is this something we should expect in vascular laboratories worldwide?
Well, this is an interesting finding and an interesting paper from an extremely busy and expert group led by Dr. Robert Thompson in St. Louis. They have an exceptional experience in aggressive management of Paget-Schroetter syndrome. This series of 214 patients who had acute axillary subclavian venous thrombosis and associated thoracic outlet syndrome tells you what a large experience is, not talking about the 63 surgical bypass patients, which is absolutely unique in this country. I don't know if any other center has this experience at all. So the finding that 21% of the duplex scans were false negative is kind of surprising, especially if it was done at an institution like Barnes Jewish Hospital, and I presume that many of these ultrasound laboratories were actually at an outside hospital and not in this hospital. All of us know that it is not easy to image the subclavian vein, certainly because there is an abbreviated acoustic window to visualize the subclavian vein because of the overriding clavicle. There is an inability to compress the subclavian vein, again, because of the anatomic location of the vein and the overriding clavicle, and that makes it more difficult. I think the fact is that only 18% of the ultrasonography report included that they had difficulties. That tells me that 82% did not really think they had a problem of imaging the entire subclavian vein, and that is something that is hard to believe. But as you know, if there is an occlusion of the subclavian vein, there are large venous collaterals that can be misinterpreted as subclavian vein, and sometimes these large collaterals, especially if it's done a little bit later from the acute episodes, they can have a pretty high flow and they can mimic subclavian vein as well. So there are reasons why people misread the ultrasound, but I believe it is clearly an operator-dependent study.
So why do you think there was such a delay between ultrasound and definitive imaging, even in patients with positive findings? And do you think we should be more aggressive about definitive imaging earlier on in patients who either have a high suspicion for venous TOS or who have positive ultrasound findings?
Overall, I believe that we should be more aware of the problem in patients who present with symptoms of swelling pain, and especially with a history of exercise that provokes obstruction of the costoclavicular angle and compression of the vein. So I believe that there must be some reason also of referral practice in this paper that gives us this data, because I presume that many patients were treated at home first or not treated, and then when they had a negative study, the symptoms increased, then they had either a repeat ultrasound or had a definitive diagnostic study, and then they were referred. So I can explain the delay in diagnosis and also the delay in treatment. So I think increased awareness of this potential problem, and based on the recommendation of this paper, even if the ultrasound is negative, if the patient has clinical evidence of axillary subclavian vein thrombosis, then we should proceed with a definitive imaging study, which is some kind of a venography.
Based on positive findings from our confirmatory studies, do you think we should be treating these patients earlier or more aggressively to try to reduce the acute thrombosis and possibly reduce the number of patients requiring bypass? Obviously, this study didn't have the goal of establishing that as a practice pattern, but can you just share your thoughts with regards to how we can improve that aspect of their management?
Well, as you know, there are several thoracic outlet syndrome experts in the United States, and some of them are more conservative and others are more aggressive. I believe if the patient, especially young patients, have symptomatic subclavian venous thrombosis, aggressive early management with thrombolysis is indicated. If there is an underlying thoracic outlet syndrome that cannot be treated with balloon angioplasty alone, then obviously more aggressive management, even surgical treatment, should be considered. But performing several of these bypasses and doing a patch angioplasty in these patients, expertise is really needed. So I would recommend that surgeons who do this type of procedures have considerable experience before they do this type of venous bypasses. And certainly Dr. Thompson's group is one of the groups in this country that has outstanding experience.
Thank you very much, Dr. Gloviczki. If any of our listeners are curious to learn more about thoracic outlet syndrome, we had Dr. Julie Freischlag on the podcast recently, and she talked a great deal about thoracic outlet syndrome. So I encourage our listeners to go back and listen to that episode as well. Anyway, Dr. Gloviczki, thank you very much for coming aboard and for starting this new collaboration with the Venous and Lymphatic Journal. We look forward to continuing this collaboration with the Journal of Vascular Surgery, and I think this will be a great addition.
Well, we are very happy to continue this. I'm sure that our arterial journal, the Journal of Vascular Surgery, will be a good example to follow with these podcasts. I should mention that this is a bi-monthly publication, so we are going to come back now with the March issue, and it will be Dr. Peter Lawrence, who is going to introduce the 4 papers. And I would like to mention again that the website for the journal is www.jvsvenus.org. And again, the visual abstract of these papers are available, and they summarize the key message of each of the 4 papers that we discussed. We are looking forward to your comments and suggestions on how to improve these podcasts. Thank you very much.
Yes, and with that in mind, we'd like to encourage all of our listeners to fill out our fall 2019 listeners survey so that we can continue to improve the podcast and continue to bring you the content that you like. Thank you very much, Dr. Gloviczki.